We are starting the session. First, sharing the first session. Now I am inviting Dr. M.K. Srivastava to please come on dais. Dr. G.S. Singh, sir. Sir, please come on the dais. And Dr. Rohit Tiwari, sir. Please come on the dais. The first speaker is Dr. Sandeep Bansal, sir, who is professor and head and medical superintendent of Department of Cardiology, medical superintendent, Safdarjung Hospital. Sir have more than 100 research papers to his credit, one of the renowned cardiologists of the country, and he is alumni of King George Medical College as well. I invite Sandeep Bansal, sir, to deliberate his talk. Sir.
Good morning, everybody, chairpersons, dear friends. My job this morning is to talk about, it's like a quick recap about beta blockers and also talk about the concept of cardiovascular continuum. So, what exactly is cardiovascular continuum? This concept came in about 31 years ago, 1992, this concept was brought in, which basically said that there is a continuum of risk factors and there is a progression of the cardiac disease in an orderly manner, as is shown here. So typically you have structural changes like atherosclerosis in the arteries and left ventricular hypertrophy, which goes on to the various manifestations of cardiovascular disease that are shown here, and finally it ends up in heart failure leading to death. The yellow bar highlights the point that the intervention to save anybody can start anywhere in this continuum, and they do help. The pathophysiology of this cardiovascular continuum consists of a number of mechanisms such as oxidative and mechanical stress, inflammation, tissue dysfunction, and later on down the line you have heart failure and also end-stage renal disease, as is shown here. It has also been known from the same concept that both lifestyle modifications in the form of diet, smoking cessation most importantly, and moderate physical activity, they help in the improvement of the in the cardiovascular continuum. Anywhere, wherever, at whatever stage you act, you do bring in benefit. There is also the concept that is catching on now of the duration of the healthy lifestyle. So you start the patient on statins, you bring his LDL cholesterol low. It is not just how much you bring it low, but also for how many years the patient lives in that state. So likewise, any intervention in cardiology, the earlier it is started, the better it is. So in terms of pharmacological therapies, it has been seen that if you start with the risk factor of hypertension, then whether you use diuretics or ACE inhibitors or ARBs or beta blockers or calcium channel blockers, they all reduce cardiovascular morbidity and mortality, and statins are also an important class of drugs in this particular category. And my focus in the cardiovascular continuum is going to be on beta blockers. They are, as we all know, an important cornerstone, and they have a lot of therapeutic importance. And in terms of risk factors, they target one of the most important risk factors for cardiovascular disease, and that is hypertension. We are aware that majority of the patients need 2 drugs at least for the management of hypertension. And these guidelines from the European Society of Hypertension came in just about a year ago, and they reiterated the fact that beta blockers, although they have been a point of lot of debate across the world, but even as late as 1 year ago, it has been reaffirmed that beta blockers can be reused. One of the important groups where beta blockers are useful for hypertension is if you have a tachycardia, and it has been seen that the cutoff given is 83 beats per minute. If your heart rate is more than 83 beats per minute and you're a hypertensive, then beta blockers are a good drug. And as this study from our own country shows, almost 2/3 of people have symptomatic, sympathetic overdrive. So beta blockers are an important group of drugs, and beta blockers are also important because of all these factors which suggest sympathetic overactivity. It has also been seen that a number of patients, approximately half of them, have high renin levels, wherein the beta blockers can be used. And so to bring about a comprehensive neuroendocrine blockade directed towards sympathetic and renin-angiotensin-aldosterone system, the combinations are available. An important one among these, as we know, is a combination of bisoprolol and telmisartan. We are also aware that this combination can be helpful in several types of people with several types of indications, as are highlighted here: stage 2 hypertensive patients with compelling indications or sympathetic overactivity, and by various mechanisms, as are highlighted on the right side. The beta-1 blockade helps, and importantly in CKD patients also. We are also aware that bisoprolol, as we all know, is perhaps the fastest growing beta blocker in the country, and is available in 3 different combinations, as are highlighted, with different indications, use of different combinations in 3 different drugs. We are also aware that by targeting both the renin-angiotensin system and sympathetic nervous system, and also with the help of bisoprolol, and also by using amlodipine to target the peripheral vasculature, we benefit the entire cardiovascular system. The usage, shifting gears now to coronary artery disease, we know that beta blockers are cornerstone in management of ischemic heart disease, and these are the different mechanisms, including the regression of atherosclerotic process, reducing the rate of reinfarction, decreasing chances of ventricular fibrillation, all these by decreasing predominantly myocardial oxygen demand. There are several trials available with different beta blockers, and this is a host of trials that are available with bisoprolol that I'm stressing upon today. So there is a plethora of data. We oftentimes say, what is the evidence? Every meeting you go, somebody will get up and say, why use beta blockers? So this is a meta-analysis that was published about a year ago, a review in the Journal of American College of Cardiology, which clearly showed that the composite endpoint of death, hospitalization for heart failure, or myocardial revascularization and also hospitalization for myocardial infarction, at least the 2 parameters were significantly decreased. It was also seen that there was an absolute difference that was 1.8%, which is fairly high, and the results were predominantly by decrease in incidence of myocardial infarction. And given the size of this study, almost 28,000 patients, so this reaffirms a clear fact puts aside a lot of doubts that we have in our mind as regards cardiovascular protection. One of the longest studies that has been published about 5 years ago with a 14 years follow-up was whether when patients were either put on beta blocker or not on beta blocker, and among beta blockers, bisoprolol versus other beta blockers, and it was clearly seen that bisoprolol scored a lot over the other beta blockers. The NICE guidelines, in fact, now shows that across the world, wherever you go, bisoprolol is the largest selling beta blocker, as is shown here. Even in our own country, it is giving a hot competition to metoprolol, as is highlighted here in the Asia column. And this is also currently an important beta blocker used after acute coronary syndromes. In terms of heart failure, as we see here, beta blockers are associated with significant mortality benefit and also risk of hospitalization benefit. We are all aware that bisoprolol had CIBIS-2 trial, which showed a 34% reduction in primary endpoint, and almost every single endpoint showed a significant reduction. There is a CIBIS-3 trial in which it was compared whether it was useful to start enalapril first or bisoprolol first. And it was seen that there was a 50% reduction in sudden deaths if you started these patients on bisoprolol first. And even in the combination phase, those who were started on bisoprolol first, they had a 46% reduction in sudden cardiac death. It has been shown to, we are oftentimes arguing that why not use carvedilol? That is another wonderful drug used in management of heart failure. So there are studies to show that when these patients have been shifted from carvedilol to bisoprolol, the symptoms such as of dizziness and hypotension have changed significantly. Also, the NYHA class has changed significantly, as has been shown in the right-sided cartoon. This is again, it's a analysis of different studies which have compared the different beta blockers, and it has been shown, if we can see at the bottom of the slide, that there is a statistically significant 25% shift towards bisoprolol in terms of benefit, and this is also associated with a greater significant increase in left ventricular ejection fraction. So heart failure comes with comorbidities, and these are the different comorbidities that we are aware of: diabetes, atrial fibrillation, chronic obstructive airway disease, and chronic kidney disease. Patients who have severe heart failure, even in those patients, bisoprolol has been found to be beneficial in terms of reducing defibrillation, improving defibrillation rates, and also in reducing the biological markers. It has also been shown to benefit the patients who have diabetes far more than other beta blockers. If your patient has COPD, unless he is having active, really severe Vs, one can clearly start these patients on bisoprolol, and it is associated with a statistically significant benefit, irrespective of what dose you use, whether you use a high dose or a low dose. The benefits are very clear. There is a survival benefit also associated when these patients with a coexistent COPD are put on bisoprolol. Patients on hemodialysis, even though they can be put on bisoprolol, so with or without hemodialysis, again, bisoprolol is useful because it has got a mixed excretion. So the take-home messages are that in terms of coronary artery disease across the board, whether it is stable coronary artery disease or it is post-myocardial infarction state or post-ACS state, bisoprolol has been found to be useful, causing a mortality reduction. As far as heart failure with reduced ejection fraction is concerned, it is one of the three important choices that are available. Although there are no differences in the mortality, but there are a lot of areas where you can use bisoprolol as compared to other drugs, including carvedilol and metoprolol succinate. And in each of these categories, it has been found to be useful. Last but not the least, why should I preach what I don't practice? In my own practice, I use a lot of bisoprolol, and in fact, it's the largest bisoprolol that I use. Why do I do so? Because it's got the highest beta 1 selectivity. This is not useful in terms of heart failure, but it is useful in terms of comorbidities. Whenever you have COPD, for example, I would choose bisoprolol. It has, as it shows, minimal effects on lung functions, very minimal effects on lipid profile, and the other good thing is it is once a day and it has got a very smooth action. In terms of equipotent doses, it causes about a 5 beats per minute greater heart rate reduction. So at least if I prescribe 100 beta blockers, so almost 80 would be bisoprolol and 20 would be metoprolol succinate, in terms of heart failure or in terms of coronary artery disease or in terms of hypertension. So as we see across the board in the cardiovascular continuum, wherever you wish to use beta blockers, this is a good choice available. The earlier in the continuum you start, the greater is the benefit, and you give a longer reduction in mortality. Thank you for your kind attention.
Thank you, sir. If any question or comments, please ask.
And if we talk of the patients who have low baseline blood pressures.
Low
Baseline blood pressures.
Yes.
Yes. So, carvedilol, I think this have BD dosing, and it have you can go within 3.1 to 5 half mg. You can start half with the dose in a daily in a divided doses. So I think in those group of patients, it's better tolerated than bisoprolol. What I feel.
No, I think if the carvedilol has by itself a fairly profound hypertensive effect, because remember it has got a alpha blocking action also. Bisoprolol on the other hand doesn't have it. You can start with an extremely low dose. You can start with a 1.25 milligrams dose. The regular titration is only two doses, 5 milligrams and 10 milligrams. But for a heart failure patient, wherein we have a fear like what you are saying, one can always start with a 1.25 milligrams dose and up titrate as the blood pressure improves and the heart rate reduces. So we do have that choice. Carvedilol comparatively has a greater reduction in blood pressure in heart failure patients.
Actually, in our practice, what we do, we have 3 FDA approved beta blocker for heart failure. First is metoprolol, second one is bisoprolol, and third one is carvedilol. What we see in our practice that the maximum heart rate reduction without lowering much blood pressure is with metoprolol. I think you will agree with me. And bisoprolol is having antihypertensive as well as heart rate reducing property in balanced way. Whereas with carvedilol, the heart rate reduction is not much profound, but blood pressure reduction is more pronounced. So if what is our target in treatment of heart failure? If we are our target is to reduce heart rate, it is always better to go and if the blood pressure is borderline, say systolic blood pressure is 100 or like that, in those situations, I think metoprolol is better option. But if blood pressure is 120, obviously bisoprolol has a very good result with that. Yeah.
Yeah, so those would go with what we have as, our own practice points, and each one of us builds up their own practice on the basis of certain observations that we make. As far as published literature is concerned, it shows that beta blocker has a much greater heart rate reducing effect as compared to both metoprolol and carvedilol. And I gave you the figure also, at least up to 3 to 5 beats per minute greater reduction per milligram of equipotent doses. You're absolutely right. I was also in the same frame of mind almost 20 years back. The Cardiological Society of India meeting was held in Bombay, and the PI of CIBIS 2, bisoprolol in heart failure trial 2. So he made his presentation, and I caught him outside the seminar room, and I said, look, what you are saying, these are the advantages of metoprolol succinate and these are the advantages of carvedilol. Why do you say you go with bisoprolol? So he said, look, all of them, you pick up any one of them. The choice is absolutely yours, and that is my advice to all my youngers who are in practice of cardiology or deal with patients of cardiology. Pick up any one of the beta blockers, establish your confidence in that beta blocker, and over a period of time you will know which beta blocker suits your mind both. You break away from that beta blocker only if you find problems. You have a patient of associated COPD, you are bound to have problems with carvedilol, which is a non-selective beta blocker. When I have to choose between metoprolol and bisoprolol, because I didn't show that slide for want of time, but it has got almost a 17 times greater beta 1 specificity. So this one beta 1 selectivity means one beta 1 is blocked, one beta 2 is blocked. So here 19 beta 1 receptors would be blocked and one beta 2 receptor would be blocked. So unless your patient is floridly symptomatic, he is going to get the benefit of beta blocker. So in all these categories, so you break away whenever you find that this patient is not suitable for my preference of beta blockers. But in general, this is the simple advice. Stick to a beta blocker of your choice. I'm not here to say that you must prescribe bisoprolol. Prescribe the beta blocker of your choice in heart failure particularly. Break away from it whenever you find a problem.
Thank you, sir. Thank you, sir. Now I request, sir. Now I request Dr. P.R. Sinha, sir, to give memento to Professor Sandeep Bansal, sir. Because sir flight is early, so sir have to leave. अच्छा नहीं फिर भी हम